radiologist to the PGs of Rog Nidan. Our organization is duly registered under Society Act 1860 at Charity Commissioner Office, Nagpur. Postgraduate students, teachers of Rog Nidan and Vikruti Vignan and Chaya Vikruti Vignan and postgraduates of modern diagnostic subject can become our members. Ours is the only organization which is fighting for the lawful rights of Rog Nidan and Vikruti Vignan PGs. Even the NCISM had also directed State of Maharashtra to consider RVPGA as a stakeholder in constitution of pathology regulatory body of the state. RVPGA is pursuing this matter of lab permission with state and central government. Not only this, RVPGA is constantly pursuing the implementation of NCISM salary structure in all the private Ayurvedic colleges across the nation. All the communication and details are uploaded on our website www.rvpganagpur.com. Some of our activities: regular conduction of online webinars and offline seminars, both on national and international platform. So far, now we have conducted 33 national webinars on different diagnostic topics, and this is our 36th academic activity. We have conducted a national conference on X-ray diagnosis at Nagpur. Our second national conference on CT scan diagnosis is scheduled on 20th October at Nagpur. Hands-on training program for PGs at our partner NABL accredited pathology labs at Mumbai, Nagpur, Pune, and many other cities of Maharashtra. We have conducted a microbiological hand-on training program for our PGs on 9th March 2024 at Nagpur, and we will be conducting the workshop on molecular pathology techniques on 19th October 24 at Nagpur. Publications of research paper of Nidan student and faculties in our peer-reviewed international journal of diagnostic and research. Interested can visit journal site www.ijdrindia.com. Our journal is enlisted in 8 databases. 2 issues have been published. Edited book volume series through our international publication RIPI, which is registered in Government of India's ISBN portal. Those who want to contribute book chapter can visit RIPI website through www.rvpgaiip.com. We have published All India Rog Nidan PG thesis book consisting of all the Rog Nidan PG titles from 1985 to 2023 for the easy reference of our PGs and faculties. This year, we are publishing All India Rog Nidan PhD thesis book. We are giving legal fight for the issues of Rog Nidan and Vikruti Vignan PGs at appropriate forums. We have our YouTube channel and Facebook page where you can see our educational activities past and live. Here, I would like to quote President Obama's campaign slogan, "Change we can believe in." Under the guidance of Team RVPGA, I can proudly say, yes, definitely we can. Thank you. Over to you, Darshana ma'am.
Thank you, Dr. Amol sir. Now, I would like to introduce today's eminent guest speaker, Dr. Arati Kulkarni madam. She is MBBS gold medalist, MD General Medicine gold medalist, DNB Neurology. She has extensive practice in Navi Mumbai. She has her own neuro center at Kharghar, Arogyam Comprehensive Neuro Care Center with facilities such as EEG, Botox, and NCV EMG. It is Navi Mumbai's first comprehensive neuro care center with one roof solution for neurophysiotherapy, psychology, psychiatry, speech and swallow therapy, and pain management clinic. Dr. Arati is also attached to different super specialty hospitals like Apollo Hospital, Terna, MGM Group of Hospitals, and MP City Hospital. Her area of interest are stroke, epilepsy, and neuroimmunology. She has vast experience in treating the headache disorders and stroke patients. She is also an active member of Angel Initiative for Stroke Thrombolysis for acute stroke care and doing public health awareness for it. So I welcome you, ma'am, and I request you to start the session.
Yeah, thank you very much for a warm introduction. So, without wasting my time and our time, most probably, I'll start with our today's session. Can I share the slides, madam, please, if you can permit?
Yes, ma'am.
Just let me know if it is visible. Is it visible, madam?
Yes, ma'am, it's visible.
I would like to thank the speakers and for giving me the opportunity to talk. So today's session, I would definitely like to keep as interactive session. I have a lot of patients of epilepsy. We have a data of more than 7,000 patients, which we have seen over the last 10 to 12 years. And a few of the interesting cases I'll be discussing here. So let's start with the beginning. Few interesting slides. What is epilepsy? What are the seizures? And how to be differentiate as a neurologist, the which type of the semiology, what is the diagnosis for the seizure or epilepsy, and accordingly, how what is the treatment protocol. So today's session, at the end of the session, you will be confident to treat epilepsy patient at your level. So whenever any complication arises, definitely you can refer to the neurologist. But in the primary settings, with this today's PowerPoint presentation, maybe you will get that much baseline idea to treat patients effectively and keep them in under your follow-up in the long run if the patient comes to you with the presentation of seizures. So epilepsy is very common in the India. 1 out of 10 can also be affected with the epilepsy any time in their lifetime. Most of the time we treat them with the anti-epileptic medications when it comes to the epilepsy. Sometimes the question is asked, what do you mean by seizure? What do you mean by epilepsy? Epilepsy, we always say when the patient is having more than 2 episodes of seizures, then it is called as epilepsy. Single episode of seizure, which is happening because of excess of electrical discharges in the brain, and that is giving rise to a phenomenology of seizure, then it is called as a single seizure, whether it can be a provoked or it can be unprovoked. So most of the individual, it is a provoked seizure, like first time hypoglycemia, first time hyperglycemia, hyponatremia, patient is having diabetic ketoacidosis, or patient is on medication which is triggering the seizures, substance abuse like alcohol, cocaine, and sometimes there are certain factors like the viral infections in the brain. So in such cases, patient can have only one seizure. The chances of getting lifetime risk of the seizure would be less than 30% in such group of patients. Epilepsy, when there are more than 2 episodes, in such group of patients, we have to keep patients on anti-epileptics. Most of the time, the patient come to us with the acquired and the genetic causes. We'll be discussing those causes subsequently in the next slides. So as per the ILE, that is International League Against Epilepsy, we say epilepsy as two unprovoked seizures which are occurring 24 hours apart, or a one unprovoked seizure with the probability of having further seizure is at least 60% occurring over next 10 years. This is called as diagnosis of epilepsy syndrome. So as I said, epilepsy is very common and we differentiate epilepsy as per ILE into focal, generalized and unknown onset. So in focal, we have a motor onset focal or a non-motor onset focal with impaired consciousness. Initially, we used to call that as complex partial seizures. So nowadays, we call that as a focal onset seizures with impaired awareness or without impaired awareness. Generalized seizures. And there's something called as the unknown seizure onset. Definitely, when any patient comes to you, you have to ask what is the seizure semiology? Is there any aura? How does the seizure end? After that, we try to make a diagnosis whether the seizure is coming from which part of the brain, whether it is coming from the frontal lobe, whether it is coming from the temporal, occipital, parietal lobe. Each lobe has a characteristic features of seizure development. And mind you, only the brain cortices we can give you a seizure. Cerebellum will never give you a seizure. If the patient is getting stroke in the cerebellum, that patient will never going to have seizure in his lifetime. If the strokes are occurring in the basal ganglia, seizures will not come. There has to be a primary pathology in the cortices of the brain cortex, which is either in the frontal, parietal, temporal, or occipital lobe. Then only one can throw a seizure. So how do we investigate? We take a history, we make a possible diagnosis, we take a family history, and at the same time childhood history. After that, we ask patient to do only two investigations which are required from neuro point of view. These are MRI, epilepsy protocol, and EEG. At the same time, we do a routine blood workup. Once the evaluation is done, we do a epilepsy counseling for the family members, for the patient. We calculate the risk, possibilities, probabilities for the future recurrences. We give them a certain advices for further of epilepsy management point of view. The drug adherence, the compliance of the drug, and the faith on the treatment as well as on the treating doctor, which is very much important, and the overall general comprehensive care of the patient. So as I said, the history definitely matters. I'll show you few videos, 4 to 5 videos. All of you can see every video, each and every video has a characteristic feature, and accordingly we diagnose and treat the patients. So anything which is happening acutely with the central nervous system, patient can have acute seizures. For example, diabetic ketoacidosis, hyponatremia, strokes, or a cortical venous sinus thrombosis. In such cases, anti-epileptics for a one seizure we don't give. When the patient is getting second episodes, we add anti-epileptics, and the course of those, when there is a electrolyte imbalance or a sugar abnormality, if there are two seizures occurring, we give only for 3 months. We don't give for more than 2 years. If we identify a seizure as a genetic or a long-term possibility, we give minimum 2 years course. We'll just go through the video. You can just see the videos. All the videos are taken with the patient's consent, and I'll be showing you 5 to 6 videos to differentiate the types of epilepsy. This patient, elderly gentleman, had come to the hospital with a history of seizure at home, and moment he reached the hospital, he threw one more seizure. I'll play the video again. So if you look at him, just look at him, he's having the seizure onset, which is coming from most probably from the left side. Left side face is getting deviated on the facial deviation on the left side. Left side face is more twitching. The left hand is in the tonic posture. However, he is able to move his right hand. We can see in the video again. With the right hand, he lifted his right hand and he touched. See? So, in this patient, this is a focal seizure with secondary generalization, and the seizure is coming from the right side frontal cortex and the hand and the face area. That's why he is getting left-sided focal seizures. This patient was very difficult for me to diagnose initially because the history was not given clearly. But when the video was brought, this was the video. See, there are episodes of lip smacking, swallowing movements. At the same time, during this episode, patient is not responding with the eye movements like this. So this is complex partial seizure, or what we can call a focal seizure with the impaired awareness, and it is coming from the frontal cortex. Next seizure. If any of the audience, if you are willing to answer, you can just unmute yourself, and you can just answer, and you can again I will answer the further questions. Third video. Let me know from where it is coming. So anyone would like to answer this video and the question, whether it is coming from the which part of the brain? Am I audible?
Yes, ma'am.
So I would just answer this. So this is not a true seizure. If you look at the semiology, there is no tonic-clonic gesture. Patient is just moving randomly. They are not occurring with the fixed phenomenology. Most of the time, if the seizures are the true seizure, every time they occur in the similar pattern. Even though patient is getting 10 seizures in a day, they will not have a bizarre pattern. They will have a similar pattern. This patient is not having any tonic-clonic movement. When we took a history, initially she was loaded with the anti-epileptic, but moment we saw the video and we did a video EEG for this patient, we got to know that there is a familial stress from the in-laws side. So we identified the stress, we did a family counseling, psychologist evaluation, psychiatry treatment, and the patient recovered later on. So not necessarily all seizures are true seizures, those who are coming to your OPD. Always you need to take a history properly. There are possibilities that sometimes you can encounter a patient of non-epileptic attack disorder. So that history and the semiologist seeing by asking them to get a video is extremely important in such group of patients. Next, I'll play. What is this? If anybody wants to answer. If anybody would like to answer. Yes.
Rheumatic chorea.
This is also a non-epileptic attack, sir. So I kept this video purposely because most of the time doctors say that only females can get non-epileptic attacks or a pseudo seizure, which is not true. The males can also have it. They can also have a problem in handling their mental stress. So if you look at his hand movements and the eye movements, at times he is focusing on the video also when the video is getting recorded. And he is doing a bizarre movements which are not synchronous. So that's why it is called as non-see. When we took his history, he had some stressor in his college. He never wanted to go to his college, and whenever the parents used to ask him to go, he used to always present with this kind of a gesture. Next, this video is classical of one peculiar epilepsy. If you look at her, see this video very carefully. She is confused, looking here and there. So in this video, we can see a confusion, looking here and there. But at the same time, if you look at her right eye, just see again. So she is just blinking only of her right eye. This is classical of right-sided eye blinking, which is coming from the left occipital lobe. It is nothing but the left occipital lobe epilepsy. And because of that, patient is getting a complex partial seizure or a focal onset seizure with an impaired consciousness. Next. There are certain difficult patients also, they come to us. For a neurologist also, it is difficult to treat and manage such category of patient. This patient was already seen by 3 neurologists and he had come to me for an expert opinion. And just mind me, all those 3 neurologists were senior to me. And I don't know, I mean, sometimes I start wondering with what intention he had come to me if my seniors have already seen him. So initially he started getting right upper limb focal seizures. First, 2 neurologists diagnosed him as a non-epileptic attacks or a stress-related seizures. But one fine day, he developed proper generalized tonic-clonic seizure. Then the third neurologist revised his diagnosis as a right focal seizure with a secondary generalization. And first 2 EEGs were normal. The third EEG showed the ictal pattern during the seizure, and the seizure was originating from the left frontal cortex. And after that, this story started around in the month of April. And the patient came to me in the month of July. So this video was taken in the month of August. So he had come to my center when I recorded this video. So just look at him. He's having a right focal seizures. And since month of May, those seizures were continuous. And since it was a right hand, it was affecting him to do his day-to-day activities, doing his job, using laptops, using mobile. Everything was difficult for him. So in his case, the primary MRI was already done, which was normal. I asked them to get a 3 Tesla MRI, which also turned out to be a normal. I did the EEG, which showed a ictal pattern. Means these are the focal seizures which are coming continuously from his one side of the brain. And we are not getting a diagnosis. CSF was done, that was normal. Autoimmune paraneoplastic panel was normal. PET scan was done, that was normal. Whole body PET scan. Then I had to tell a relative that we are dealing with a case of seronegative autoimmune encephalitis or a Rasmussen's encephalitis. So in Rasmussen's encephalitis, one part of the brain starts throwing a seizure over a period of next 2 to 3 years. The disease evolves. It can involve the half side body phase. It can cause a paralysis also on the same side. At the same time, patient can also develop a behavioral disturbances, cognitive issues, anger outbursts, hallucination, delusions, illusions, and the serological workup, matlab CSF workup and the blood workup would be negative for this group of patients. Told the relatives, I counseled them, I started patient on immunomodulation like IVIG and rituximab. In spite of that, still I thought of taking a help from my senior colleagues from the south in Kerala Sri Chitra Tirumal, which is the Epilepsy Institute. And from there, we got a help, and I had referred this patient to the one of the epileptologist also, but just to get a cross check whether I'm doing treatment correctly or not. So he said whatever is going on, it is absolutely correct. And we went ahead with the PET scan of the brain. And PET scan clinched the diagnosis, and the diagnosis was correct. Look at the PET scan. You can see that red color spot which is coming from the hand area of the brain, and it is coming from the left side of the prefrontal gyrus. So this is nothing but the Rasmussen's encephalitis late onset. And this seizures phenomenology is because of the encephalitis. We counseled the relatives got convinced, and the plan is to keep him on rituximab every 6 monthly for further years till from now. And he has already received 2 doses of rituximab. So this was one of the difficult case recently which we have dealt with, which is epilepsy patient in the epilepsy patient category. And such kind of patient also we come across, and we know how to manage such kind of patients with the great efforts and the patience. So the management, I'll just make it very simple because now only 15 minutes of slides are left. Any patient when you see in your OPD for your epilepsy, those who are having an epileptic focus, always we try to give them a safe medications. So what was the treatment practice around what we can say around 20 years back? The drugs which were used nowadays, most of the drugs are getting replaced by good quality drugs with the lesser side effects, looking at the patient's life expectancy, patient's compliance, and patient's functional capacity. The certain category of patient where we have to subject patient for a surgical excision, removal of the causative precipitating factors, and the physical and the mental health of the patient matters. Initially, if you'll ask the people, those who are practicing, when they started practicing in the late 80s, around 1970, 1980, the primary drug of choices were the first medicines what we used to use in the first column: phenytoin, phenobarbital, valproic acid, primidone, clonazepam, and carbamazepine. Second generation, third generation medicines have definitely evolved over a period of years, like levetiracetam, lamotrigine, oxcarbamazepine, vigabatrin, topiramate. And third generation, like for our new generation, lacosamide, perampanel, rufinamide, fosphenytoin, brevetiracetam, and aceclidine. Each drug has its individual characteristic. And mind you, let me tell you, second, third generation medicines are the gem of the medicine with the very less side effects and the good efficacy and good tolerability when it comes to the compliance and reducing the toxic side effects of the patient to the patient. See, this is the evolution, how the every drug has evolved over a period of year and the mechanism of action of all the drugs. So I will not go in detail, but always we go for a sodium channel blockers, we go for a synaptic vesicle blocking proteins, we go for a something called as a calcium channel receptor gated mechanism, we go for AMPA receptors. So accordingly, we choose the anti-epileptic medication. So all patients, every patient is different. Every patient's epilepsy syndrome is different. The patient's profile is different, and accordingly, the AED has to be chosen and it has to be continued further with the patient's compliance and patient's understanding. Most of the time in US busy clinical practice, the safe drug to give is levetiracetam because the side effect profile of the medicine is very less. When we diagnose the syndrome and when we have to upgrade the medicine, that time maybe we can go for a selective medicine which is suitable for the patient. For example, like in focal seizure, we have a lot of medicines, but when it comes to the generalized seizure, the selective medicine what we use is something called as a valproic acid, topiramate, levetiracetam, lamotrigine. In myoclonic seizures, we know only three medicines will work, like valproic acid, lamotrigine, levetiracetam, and topiramate. And in epileptic syndromes, we use something called as vigabatrines, levetiracetam, lamotrigine, and topiramate. So I will not go into anti-epileptics which are used as per the category. But in females, if you'll ask me, in my practice, I never use the drugs which can produce the effect on reproductive system. So I will never load a young female with eptoin, or I will not give her a valproic acid anytime in her lifetime when she comes to a reproductive age. Never as a just for giving in the casualty also in the for a single seizure. Definitely, but somebody goes in the status, our drug of choices might differ. But when it comes to a female patient managing such kind of patient, because looking at the pregnancy, postpartum, we have to be very much selective when it comes to giving anti-epileptic drugs. So definitely diagnosis, treatment, eradication of epilepsy, counseling of the patient, and the long-term compliance matters in the epilepsy. So there are various patient-related challenges. A lot of the time we do a lot of social education through social media platform for understanding epilepsy, giving them a compassionate, passionate care, understanding the epilepsy patient, their psychology, and giving them all kind of possible job opportunities. That is extremely important for the society. Most of the time patients face the challenges like social isolation, they're dependent, their psychological psychosocial changes, their reduced quality of life, economic burden because of the pills or maybe because of the disease itself, and the adverse effect. The physician related challenges, definitely diagnosis, choosing the correct anti-epileptic drug to drug interaction. Sometimes epilepsies are not controlled by one seizure, we have to add first, second, third add-on. Specific population we have to pay more attention to, and the comorbidities definitely we have to consider under one, and then accordingly we have to choose and select the medication. So we know the path is twisted and it is not difficult, but still we help patient to ride on that path easily to smoothen their journey of life. So balancing the anti-epileptics by giving them a good care and understanding about the disease definitely helps. You can use one or two anti-epileptics when it is needed as an add-on medication. Definitely, we also go for a therapeutic drug monitoring in the few group of patient when we know the patient is not compliant, or patient is pregnant, or patient is having infrequent seizure, or a multiple drug therapies are required. That time we go for a therapeutic drug management. Now, what are certain do's and don'ts for epilepsy? So when any epilepsy patient who is newly diagnosed by me, we always do a counseling of the patient. We tell them ki epilepsy, definitely you have to take a medicine. You need to have an understanding about the disease. You need to have ID in your card. The family members are been explained that when the any patient shows seizure, the patient has to be taken to the safe place, has to be turned on one side, and the once the seizures are brought under control, the patient should be taken to the neurologist to whom or the nearby hospital from where they can receive the treatment. Do not use any keys. Do not use any thing to put in the patient's mouth during seizure. Do not uh, what you call, do not try to hold or grab the patient very tightly, otherwise the patient's breathing gets hampered. And you always take a help of the specialist. Considering the job profile, we say there are certain jobs where the epilepsy patients are strictly not allowed, like aircraft pilots, ambulance drivers, merchant seamen, the taxi drivers, the train drivers. So basically the driving and the swimming task when they're involved. So in such kind of things, the patients are, epilepsy patients are not allowed. Shift duties are not allowed for the patient because most of the seizures can get triggered if the patient is not sleeping at the night time. The various occupational hazards when they are likely to occur, that time the patient has to be very much careful. We do not allow a patient to work in the underground machinery workers or the work with the plenty of where it involves the plenty of driving and construction work sites. Definitely, driving for a can be undertaken only if the patient is 1 year of seizure freedom is there. Otherwise, we ask patient to avoid driving. And water hazards, water related activities, definitely we don't allow them. And if the seizures are not under control, we ask patient definitely not to take a bath with the closed door, because in case of the help needed to be given, such cases the help is not possible to give it to the patient. So this is what is explained on the first day only when we do a counseling for the patient, and we treat patient and we keep them for a long term follow up. Thank you very much. Any questions?
If anyone has question, please type in the chat box or you can directly ask ma'am.
Madam, could you please throw some light on autoimmune encephalitis and occurring epilepsy? I mean, antibodies related to that.
Definitely, it's one of my interesting topic, and I would always like to talk about autoimmune encephalitis, because recently I will just discuss one case. One of my patient's relative, they stay at Canada. They had come to me for a video consultation. So the patient's relative met me. So in autoimmune encephalitis, always the history goes like there are certain seizures which are occurring as a focal seizures, and they're not getting controlled with the one anti-epileptic medication. The history is short onset, previous history is not there, family history is not there, and most of the time the scans are normal and the seizures are not getting controlled by one. Over a period of time, patient along with the seizures, they get the other problems like behavioral problems, anger outburst, personality change, mood swings, depression, hallucination, delusions, illusions. All these things can come into a picture, cognitive decline. So this is the classical picture of autoimmune encephalitis. Acute to subacute onset with this pattern and with the seizure which is coming into the picture, not responding. Like a way I had shown that video of the guy, he's on 4 anti-epileptic medication and he's on the full doses of 4 anti-epileptic. In spite of that, I could not control his seizure. So that Canada patient, when they had come to me, she used to get 5 seizures in a day. And the she was in the Vancouver General Medical Hospital over there in the Canada, and they had come to me for a second, what you call the second opinion. And the diagnosis was not made at that time. It was just diagnosed as an epilepsy focal onset without impairment of consciousness or with impairment of consciousness. So I had just asked for a one investigation looking at her age. She was elderly with hyponatremia. Certain autoimmune encephalitis can come with the electrolyte imbalances also. So LGI1 was asked by my side on my consultation paper. Their neurologists, they agreed and they did the test of LGI1. And just believe me, after 15 days, I got a call from Canada saying that, Madam, we are extremely thankful to you that you cracked her case. We could diagnose her. They treated her with the IVIGG followed by rituximab. And now that patient is doing good. And anti-epileptics, what they were using were lacosamide and the clobazam. So I, in the second meeting with them, directly with the doctor, I asked them to switch over that anti-epileptic to a stronger anti-epileptics. So they said like polypharmacy, we don't do. I said, we are not, I'm not asking you to do the polypharmacy. I'm just asking you to keep first drug as the main drug. Either you keep it as a brivaracetam because lacosamide is weaker than the brivaracetam, or you can go for certain better medication which is more stronger than the lacosamide, and the immunomodulation will continue. Now the relatives are also happy, doctor is happy, and everybody is happy. But all autoimmune encephalitis are not so easy to treat because there are no definitive guidelines, sir. We try to treat patient for 2 to 3 years, looking at the patient symptomatology. And if you look at my patient, I know in the future his disease, in spite of giving the proper medication, the Rasmussen's will going to progress, and he will definitely going to have seizure progression to the leg as well as to his entire body. Maybe that might can happen over 5 to 6 years down the line, but whatever we are doing, trying to do from our side, we are doing it. So the options which are available are plasmapheresis, IVIGG, or rituximab, looking at the patient's capacity, financial constraint, and the eligibility criteria. We give the medications. Thank you very much.
Thank you, madam.
Ma'am, I have one query.
Yes.
Yes, ma'am, if epileptic patient fails to take anti-seizure or anti-epileptic medications, then in that case, what can be the treatment plan?
Fails to take means either they are not liking the treatment or maybe they're not liking the drug. So any of the cases, we have to counsel the patient. You have to ask them to continue the medicine because the medicine is the primary option that they have to take it properly. So such cases, what we do, family counseling we do a personal level counseling. We tell them that taking drug is important, otherwise your life will be at risk. So only in such cases, we don't give polypharmacy or a second add-on, we never put. We try to give one certain patients we know. I get high profile patient. They say, Madam, twice medicine we will not take. Once I have to go, I'll forget while going to the job. Only once in a day preparation. So certain patients, group of population, they strictly demand, we want only one time drug. So in such kind of patient, maybe we have to select the drug properly so that they will get a seizure freedom and whatever they want in their mind, that their wish also we can fulfill. So definitely counseling helps, and the trust of patients on the doctor and the doctors on the patient also matters in such cases.
Okay, thank you,
Is,
ma'am.
the, is there any guidelines for treating NORS?
Yeah, there are guidelines, sir, for treating NORS, but NORS, as you know, it is extremely fulminant disease. I've treated so far 2 patients of NORS. Once I was in Nanavati, I was called for a second referral. And so in certain category of patient, um, definitely for diagnosing NOS for a patient in the one day, we cannot diagnose. It takes 2 to 3 days. They go into refractory status epilepticus. All the autoimmune, paraneoplastic panel, everything comes normal. And they fulminantly evolve. They become what you call, they dependent on the ventilator and the continuous electrical discharges going on in the brain. So in such group of category of patient, the plasmapheresis works much better than the IVIGG in my experience. And once the plasma is given, we can safely give IVIGG, sir. Reverse way, we cannot do IVIGG given first, then we are doing plasma. That doesn't work in the another way around. So always we have to, while selecting immunomodulation also, looking at the patient's disease and the pathophysiology, selecting immunomodulation extremely important, and accordingly we have to treat the patient. But 90% of them, they are fatal.
And one common question of the patients in partial, whether it is a case of partial or complex or generalized seizures, that how long I will have to take the medicine.
Yeah, yes. So in such group of patients, na, sir, if it is a generalized, most of the time generalized epilepsies are the familial epilepsies, what we call as IgE, idiopathic generalized epilepsy. So in IgEs, the recurrence risk is around 30%. So in the family counseling only, we tell them it is a genetic epilepsy like a juvenile myoclonic absence or a childhood absence or a juvenile absence seizure or a idiopathic generalized seizure. So if it is falling into that category, then you have to tell them you have to take medicine for 2 years. But JME has a more recurrence rate, more than 50%. Then you have to tell them very clearly, if you're not doing lifestyle changes and the drug has been stopped after 2 years, the risk of recurrence is around 50%, and it is there in your genes. We cannot change that pathophysiology. So you might have to end up taking one medicine for a pretty long period of time till your what you call the 50s. Huh? So we explain and accordingly we start the treatment. In focal seizures, on the contrary, there are certain focal epilepsies which we can manage. Like sometimes patient is having DNET, there is something developmental malformation in the temporal area, or patient is having some cavernoma which is refractory. If we treat them surgically, they become seizure free. If the patient is having temporal lobe epilepsy, we are sometimes they might need only one medicine, but they have to take it lifelong, will not get a seizure freedom in the year of 2 years. So subsequently we'll get an idea. But in the first counseling, you will have to tell them maybe 2 years you have to take it minimum. After that, the calculated risk would be for a partial seizure, it will be around 20 to 30%. And if it is a JME, juvenile myoclonic, or a generalized, up to 50% recurrence rate. You have to tell them very clearly. And whichever category is falling into, we will not understand now. We will understand when we'll stop the drug. So the counseling of the patient is important, that the drug is taking is important. Maybe you take it for a 2 years or later on, but you have to take it in order to have a good quality of life. Anything else?
I think there is no more query. Actually, thank you so much, madam. This lecture was really interactive. Thank you so much for your valuable guidance. So we will move to the next session, the chairperson opinion, and for that we have Dr. Reshma Shah madam. She's working as professor and HOD in the Department of Rog Nidan and Vikruti Vignan in Siddhakala Ayurved College, Sangamner. She is MHS recognized PG guide since last 10 years. She has published many research papers and articles in various national and international journals. She has also invited as resource person at various national, international conferences and seminars. So I request Dr. Shah ma'am to give your expert opinion.
Uh, Good afternoon, everyone. Can I speak? Good afternoon, everyone. First of all, myself is very thankful to Rognidan and Vikruti PG Association and Organizing Committee for giving me an opportunity to chair today's session as a chairperson of today's guest speaker, who is renowned young neurologist in Mumbai and Navi Mumbai. Dr. Arati Kulkarni ma'am has explained clinical approach of epilepsy with sharing the videos and differential diagnosis and current management of epilepsy, challenges in the management of epileptic patient, and how to give the precaution and advice what to do and what to do not. And other, the patient's lifestyle issues are also talked in lucid and simple language. I hope that today's talk will give new insight to our student of Ayurveda to diagnose and manage the patient of epilepsy. And ma'am, I would like to put one thing in front of you that the disease apasmar explained in Ayurveda is having exact similarity with epilepsy, where through clinical approach and management is described in very scientific manner. Once again, thank you the organizer for organizing such wonderful academic activities. Thank you so much.
Thank you so much, Dr. Shah ma'am. One thing I forgot to mention at the beginning of the session, that this whole Naidaniki webinar series on neurology is approved by MCIM Mumbai and Nagpur University. Dr. Aarti ma'am, there is one query in the chat box, so can we take it?
Yeah, yes, please go ahead, madam.
So the question is, what are the, sorry. The question is, what are the chances to develop epileptic attacks after accidental history and having the head injury before 1 year?
The chances is if the patient is having no seizures during the road traffic accident, and if the gliosis is developing in the temporal area or in the occipital cortex or in the frontal. So in such cases, the temporal and the frontals, the risk is around 30 to 40% within first 1 year. Sometimes the late onset epilepsies we also see wherever the scar mark is, the patient can have a scar epilepsy anytime in their lifetime, depending on the criteria like not sleeping or excess of heavy schedule, patient is not eating on time. So whenever the health of the patient gets compromised, the certain areas of the brain can throw the seizures, like temporal and the frontals, they are likely to throw a seizure. But if patient has never had a seizure during road traffic accident, risk within 1 year, in spite of having a trauma or a brain gliosis in the brain, the risk is around 10 to 20% only. It is not more than that.
So they are asking if there is any anti-epileptic drugs
No.
throughout the life.
No. Throughout the life, we don't give. Unless and until they throw a seizure, patient has to throw a single seizure at least after getting a road traffic accident. Means any time in their lifetime. Maybe the RTA has happened in the month of January. Patient was all okay till 1 year. After 1 year, he has got a seizure. So after that, we will start anti-epileptic for another 2 years. We will not continuously start taking patient, continuously keep patient on anti-epileptic. Sometimes seizures can occur 5 years, 10 years down the line. So it does not mean that we will give AEDs for so many years.
Okay, ma'am. Thank you. Thank you so much. So now we will move on the last part of this session, the vote of thanks. And for that, I invite Dr. Geeta Sathavne, madam, from Datta Meghe Ayurved College, Nagpur. So over to you, ma'am. Dr. Geeta, ma'am.
Thank you very much, Dr. Darshana ma'am. The vote of thanks is the last part of this webinar. I, Dr. Geeta Sathavne, feel very honored and privileged to get the opportunity to propose the vote of thanks in today's webinar. On behalf of the organizing committee, I convey deep regards and heartily thanks to our today's guest speaker, Dr. Arati Kulkarni ma'am, for her interesting, excellent, and highly informative presentation on epilepsy and differential diagnosis and its management. Ma'am shared a various epileptic patients' videos with us, which was very useful for better understanding the topic. Thank you very much, ma'am. And it was really a feast of the day for us. Thank you, ma'am. I special thanks to Dr. Reshma Shah, ma'am, the chairperson of the today's webinar, for chairing the session and her valuable chairperson remarks on this topic. I also, and the words are not enough to thank you, our dynamic president of the RVPG Association, Dr. Subhash Wage sir, for his constant guidance and the support, and who encourage us for the excellence. And also, a special thanks to Dr. Santosh Chavan sir, the secretary of RVPG Association, and the treasurer, Dr. Vaishali Ganurkar ma'am, for their guidance and the constant help for conducting this webinar and making this webinar a successful event. I also thanks Dr. Amol Gujarati sir for their wonderful introduction of the RVPG Association. And also I thanks Dr. Darshana Ubale ma'am for the smooth conduction of this and coordinating of this today's webinar. Also, I lastly thanks the all participants who attending this webinar and making this webinar very successful. Thank you very much and have a wonderful day. Thank you, ma'am. Over to Darshana ma'am.
Yes, thank you so much, ma'am. So I think with the permission of Dr. Wage sir, we should stop here, and I think we can leave the meeting now.
Yes, I declare this session is over and we can leave now.
Thank you very much. Thank you.
And thank you, Kulkarni madam. Thanks a lot.
Thank you. Thank you.
Arati ma'am, namaskar, Dr. Santosh Chavan. Thank you for being on our platform.
Thank you, sir. Thank you. Bye.
Thank you, ma'am.
Bye.
Bye bye. See you, ma'am.
संतोष वेळ काढ